Hi everybody, my name is Aditya Daftari and this is the talk on imaging the young osteoarthritic knee. A recording of this talk is available on our YouTube channel at Innovision Imaging and also our case-based learning platform is learn.innovisionimaging.com. So to overview, what is osteoarthritis? Osteoarthritis is pain and symptoms in a joint that are caused by diffuse articular cartilage loss. It presents usually with chronic progressive pain, discomfort and swelling, and may occasionally have acute exacerbation of chronic symptoms. The treatment strategies for osteoarthritis can be conservative, which include physio and rehabilitation, injections such as steroids, PRP, and other injectables, surgical treatments which involve joint preservation surgeries such as arthroscopy, high tibial osteotomies, and unicompartmental arthroplasties, and finally complete joint replacements. How does imaging help? Imaging helps us to determine whether the cause of the patient's symptoms are actually osteoarthritis, whether this is chronic osteoarthritis or an acute exacerbation of osteoarthritis, and helping us to plan interventions, decision making, and planning. So what is the approach to the young osteoarthritic patient? A young patient with knee pain, the first question we ask ourselves is it really osteoarthritis? And besides the symptomatology, it's the X-ray and MRI that helps us. And here we're looking to see if something has a non-chondrogenic cause of pain, which could include a meniscal tear, a ligament injury, and in this case, these are managed either conservatively or arthroscopically. Alternatively, we may be dealing with a chondrogenic cause of pain. Chondrogenic pain can be because of small or large lesions, so we want to determine the size of the lesion, and again we do that with X-ray and MRI. If it is a focal lesion, then we can manage it conservatively or consider procedures such as a chondroplasty. On the other hand, if it is a diffuse lesion, then we want to know how the patient presents. So if the patient presents with acute exacerbation of knee pain and they have diffuse cartilage loss, then we want to determine the cause of that acute exacerbation and then manage either that cause, manage the osteoarthritis, or manage both conditions simultaneously. Alternatively, if we have chronic pain, then we're trying to determine how bad the extent of cartilage involvement is. If it is mild to moderate cartilage involvement, or if it is moderate to advanced cartilage involvement. In cases with mild to moderate cartilage involvement, the treatment is usually conservative with physiotherapy and injections. On the other hand, if it is moderate to advanced, then the treatment ends up being surgical. With surgical planning, the primary key decision-making step is to decide whether the disease is unicompartmental or multi-compartmental, with the idea being to really conserve as much of the original joint as possible. Here, X-rays and MRIs are extremely helpful to us in determining the extent of disease. With multi-compartmental disease, the patient will usually progress to a total knee arthroplasty or a TKR. With unicompartmental disease, we are usually interested in assessing the alignment. Once we understand the alignment of the patient's knee, we can do that using a scanogram, and then we can decide based on normal or abnormal alignment of the knee. So if you have neutral alignment, these patients will typically go to a unicompartmental arthroplasty, and if you have abnormal alignment, they will typically go to an alignment surgery such as a high tibial osteotomy or a distal femoral osteotomy. So in order to manage osteoarthritis, we need to determine if it is truly osteoarthritis through X-rays and MRI, determine what the extent of cartilage involvement is, whether it is focal or diffuse, if it is unicompartmental or multi-compartmental, determine how it is presenting, whether it is presenting as acute disease, chronic disease, or acute on chronic disease. Try to figure out what about the particular presentation we are trying to address. Is it the acute exacerbation of osteoarthritis, chronic osteoarthritis, or both components? And finally, how are we managing it? If it's just the acute exacerbation, are we using a wait and watch policy, injection, arthroscopy, or actually going to just manage the osteoarthritis? Or are we looking to manage the chronic osteoarthritis through a joint preserving procedure, such as a realignment or partial replacement procedure, or through a complete replacement procedure? Now, the next thing that we ask ourselves is there really osteoarthritis? And when we're doing this, we realize that there's an epidemic of young knee osteoarthritis. This is created primarily by orthopedic surgeons and radiologists because we don't know how to read X-rays. X-rays should be looked at carefully for obliquity, comparison with the opposite side, and standing views to determine if there is true joint compartment narrowing. MRIs, on the other hand, are very helpful in assessing cartilage through cartilage-sensitive imaging, T2 maps and cartograms, but I should repeat that T2 maps and cartograms are actually something that we do not need in the case of assessment for patients with osteoarthritis. So this is an example of obliquity. We look at the image on the left here, and what you can see is that there is apparent joint space narrowing, but this is because of the obliquity, and you can see that is because of the tibial articular surface being seen obliquely like this. If you straighten the beam and improve the image, then you can see the joint space actually normalizes. A comparison radiograph is also extremely helpful. If you looked at this radiograph in isolation, one may not appreciate the joint space narrowing, whereas if you look at it in comparison to the opposite side, you can see that it is obviously narrowed. Last but not least, weight-bearing radiographs are particularly important. If we see these non-weight-bearing radiographs, everything looks good in the joint space, whereas with weight-bearing you can see how there is advanced bilateral medial compartment narrowing. Once we're convinced of the obliquity, the comparison, as well as the weight-bearing nature of the radiographs, we can grade osteoarthritis as mild, moderate, or severe based on the degree of joint space narrowing and marginal osteophyte formation. So at the end of a basic X-ray evaluation, we should be able to identify the presence of joint space narrowing, determine whether it is real or not real using obliquity, comparison, and weight-bearing views, grade the level of osteoarthritis, and then decide whether we plan to intervene based on X-rays and clinical symptoms conservatively or surgically. But having said this, it's really important for us to note a few things. So if you look at this radiograph here, where you see definite medial compartment narrowing, when you look at the MRI, you can see the gray articular cartilage looking quite good, but what we notice is that the meniscus is extruded. And this patient who has a medial meniscal root tear with extrusion of the medial meniscus, you can see marked medial compartment narrowing, which could be mistaken for osteoarthritis, whereas actually this patient has fairly intact articular cartilage. Another example here where you can see bilateral medial joint space narrowing a bit greater on the right, we find that this is actually coming from the fact that this patient has had a partial medial meniscectomy, as is demonstrated by the completely blunted appearance of the medial meniscus here as well as here, and the articular cartilage is actually quite good. So does joint space narrowing mean osteoarthritis? Yes, cartilage loss is a common cause of radiographic joint space narrowing. However, there are many other causes, and before treating osteoarthritis, we need to confirm this with an MRI. Now, once we've understood that there is true joint space narrowing or there is cartilage loss, we want to know what is the extent and location of cartilage involvement. And the reasons this is important are we want to know if it is focal cartilage loss or diffuse cartilage loss. Here an X-ray is helpful. If you have joint space narrowing, one would indicate that there is cartilage loss, whereas on an MRI one can actually discretely identify the loss of cartilage as opposed to just assuming there is cartilage loss based on joint space narrowing. We can grade cartilage loss as mild, moderate, and advanced based on the degree of joint space narrowing on an X-ray, but on MRI we can actually see the extent of cartilage loss. When we look at unicompartmental versus multi-compartmental disease, we base this on joint space narrowing, which can be affected by varus and valgus angulation of the knee. On the other hand, on MRI, we can actually physically demonstrate that cartilage has been lost. And again here, cartilage maps do not serve any purpose. We can also determine an area of intra-compartmental involvement. Is the compartment involved more anteriorly or more posteriorly? Is it involved more medially or laterally? All through this similar process. And MRI again can demonstrate these things, even though we have tools to look at this with radiographs. So when we're looking at extent and location of cartilage involvement on X-rays, we can obviously grade cartilage loss as we showed you earlier. We can also determine which compartment is involved, the medial compartment in this case, the lateral compartment in this case, and both sides of the femoral compartment in this case. And finally, we can look at the area of cartilage that is involved. So in this case, where you have medial compartment narrowing on an AP standing radiograph, if we do a Rosenberg view, which is a flexed AP standing radiograph, PA standing radiograph, what you'll see is there is further loss of articular cartilage, indicating that the cartilage wear is more posterior than anterior. But MRI is the tool of choice to assess cartilage. We can tell normal cartilage, we can tell fissuring, small fissures, and we can detect larger grades of cartilage loss with this as well. Wear patterns in the knee, we can also see these well on MR. We can see whether there's purely medial cartilage involvement, lateral cartilage involvement, or bicompartment involvement. We can also describe the area of cartilage involved as a percentage of the articular surface area involved. When we look at wear patterns of the knee, it's important to identify medial and lateral cartilage patterns, because by changing the alignment of the knee, we can change the mechanical axis and the loading. So for example, in this patient where we see extensive medial compartment cartilage loss, if we were to do an osteotomy and change the angulation of the knee, we would change the mechanical axis to run more through the lateral compartment and spare that worn out medial compartment. We can do the reverse in this case with lateral compartment osteoarthritis by increasing the mechanical loading on the medial side. We can apply a similar thinking to if we look at the sagittal plane articular cartilage wear, and in this patient where the tibial cartilage is worn out more anteriorly than posteriorly, we can tilt the tibia downwards and therefore increase the loading on the posterior aspect. And in this case where we can see more posterior wear, we can tilt things anteriorly and we can increase the load anteriorly. So how do X-ray and MRI fare against each other, and does MRI really matter when we're looking at the degree of articular cartilage loss? So if we look at this patient, who we see a fairly good articular cartilage space here, both on the oblique as well as the straighter image, we see that the cartilage space, the joint space looks quite good, but when we look at the MR, we can see that there's fairly advanced cartilage. So radiographs can underestimate the extent of cartilage loss. Here's another example where we think that there's going to be bilateral, both the medial and lateral femorotibial cartilage are going to be lost. But when you look at the MR, you see advanced medial loss, but you see relatively good and spared lateral cartilage. So even though radiographs can suggest compartment and intracompartment condyle changes, MRI serves as a confirmatory study in these situations. Identifying unicompartmental and intracompartmental disease can play an important role in the management of conservative or joint preservation surgery. The next thing we want to look at is whether there is an acute exacerbation of pain of osteoarthritis in somebody's knee. And this can be in the form of root tears or flaps, subchondral fractures, and loose bodies and impingement. So here's an example of a patient who has relatively good articular cartilage, may have had joint space narrowing on the medial compartment on an X-ray. We see this bone marrow edema pattern here, and we see a root tear. So we know this is a person who has medial compartment narrowing, not because of cartilage loss, but because of a root tear. And along with that subchondral insufficiency fracture or that subchondral impaction fracture, that is the cause of the pain. So this patient might benefit from, instead of going into an arthroplasty type procedure, from going into something where they do a medial root repair or medial meniscal root repair, as well as doing a high tibial osteotomy that changes the alignment of the knee and allows the native knee to live longer within this patient. Here's another patient in whom we see articular cartilage loss as well as bone edema, which is an exacerbation of osteoarthritis. And here we don't have to do anything to the meniscus, but we may just want to change the alignment of the knee to spare that medial compartment more loading by doing a high tibial osteotomy and allowing that native knee to live longer. Here's a recent example from what we had at work. Here's a patient with some mild medial compartment narrowing who had sudden locking in the knee. We thought he had a loose body here because he had pain here, and this was impacted behind the posterior cruciate ligament. You can see this on the MRI. You can see that there's edema around it. So we were obviously thinking that this was the cause of the locked knee. But when he went to arthroscopy, we found that it was actually delaminating cartilage from the trochlea that was the cause of the locked knee. So there is acute exacerbation of osteoarthritis. We want to know if we are treating the exacerbation or the osteoarthritis, or we are treating a bit of both. So if we have unicompartmental osteoarthritis, what are the options for treatment? The first is, if we have mild or moderate changes, we may consider conservative action. Don't do anything, give physio, give rehab, sometimes injections like steroids, PRP, or stem cells. If we have somebody who has moderate to advanced changes, then we would consider doing something that would be helping to preserve that original joint as much as possible, whether this means a realignment surgery or partially replacing the joint by a unicompartmental arthroplasty. So now when we decide that we have unicompartmental disease, we want to know the alignment of the joint, because that allows us to determine whether we are going to just change the alignment or we're actually going to have to physically change a component of the knee itself. In order to do this, we do a standing scanogram and we try to determine if there is altered biomechanics within the knee in terms of the mechanical axes, and whether the alteration in mechanical axes is coming primarily from the femoral side or the tibial side. And we do this by measuring the angle between the mechanical axis of the femur against the axis of the distal femoral condyle, or the mechanical axis of the tibia with the axis of the medial tibial plateau. And this is known as the lateral distal femoral angle or the medial proximal tibial angle. And just to give you a quick example of how this works, here's a patient who has genu varus. When we do a scanogram, you can see these are the measurements that we get. What you can see here is that there's marked, when we look at the femoral side, there is some widening laterally, but there's far more narrowing medially of the joints of the joint space. So primary component of the varus abnormality is coming from the tibial side, and therefore this patient undergoes a medial tibial osteotomy, which means they cut open a part of this as a triangle, and then they straighten out the tibia like this to change the mechanical axis to be coming down more on the lateral side than on the medial side. Similarly, here's a patient where the problem is more on the femoral side, and therefore what they do is they perform a wedge osteotomy on the femoral side, change the alignment of the femur using a distal femoral osteotomy, and reduce the loading on the medial compartment, increase the loading on the lateral compartment, delaying the need for an arthroplasty. Here's another patient where the problem is both on the femoral as well as the tibial sides, and in this case the patient underwent a unicompartmental arthroplasty. So if we think about managing osteoarthritis, we think about it as patients presenting with acute pain or acute pain with locking. We would confirm the cause of this pain by an X-ray and an MRI. And with this, we would determine if there's a subchondral insufficiency fracture, meniscal flap, root tear, or an intra-articular body. And we would also get a status of the general articular cartilage in this patient, whether it is mild to moderately abnormal or moderate to advancedly abnormal. If it is mild disease and somebody has a subchondral insufficiency fracture, one might just wait for that to resolve. If there's a meniscal flap, you may decide to do an arthroscopy and maybe a joint preserving surgery such as a high tibial osteotomy. With a root tear, you might want to repair it and then consider a high tibial osteotomy. And with an intra-articular body, you want to remove the offending intra-articular body and then consider realignment surgery if that is an option. If somebody has moderate to advanced disease, then you want to manage the osteoarthritis. Now, whether you decide to do it with an arthroscopic removal of the meniscal flap, with a repair of the root, or with an arthroscopic removal of the intra-articular body is a different story. The third way that somebody may present is with chronic osteoarthritis, in which case you manage osteoarthritis. So how do we manage osteoarthritis? First, we want to check the compartments. Is this disease multi-compartmental disease? If that is the case, we go ahead with a total knee arthroplasty. Is this unicompartmental disease? If that is the case, we want to look at the cartilage in that compartment. If it's advanced cartilage loss, then obviously a unicompartmental arthroplasty, because there's not much effect in preserving the cartilage in that compartment. On the other hand, if it is moderate loss, then we may look at the alignment. If we say that it's neutral alignment, we could still consider a unicompartmental arthroplasty. If it is varus or valgus alignment, then we would consider changing the femoral or tibial alignment to change the mechanical axis and improve the outcome of that knee. So while X-rays are excellent, MRI plays a very important role in osteoarthritis. It helps us to confirm whether there is actual cartilage loss, which is the cause of joint space narrowing on the X-rays, or if it is something else. It helps us to understand the extent of articular cartilage loss, the size of the defect, the compartmental involvement, the degree of compartmental involvement, and the intracompartmental involvement, whether it is anterior or posterior. And all of these, as I have showed you, can have an important role to play in how we decide what kind of surgical alternative we can offer the patient. And finally, when we look at preservation versus total knee arthroplasties, we want to look at the alignment of these knees, and there the scanogram is a really, really important tool. So in summary, when we have a patient who has young osteoarthritis, we want to know if there's really osteoarthritis. We want to know if the cartilage is actually the cause of the patient's pain. If we want to know if the cartilage loss is focal or diffuse. If it is unicompartmental or multi-compartmental. What is the alignment of the knee? Are we treating acute exacerbation of osteoarthritis, just the osteoarthritis, or both? And is there a role for joint preservation or partial replacement? And finally, while X-rays play a great role, MRI does add very significant value. Last but not least, scanograms are invaluable in joint preservation decisions. So once you understand this entire global appearance of osteoarthritis and the role that the management of osteoarthritis, I think it will become much easier for you to understand the role that MRI plays and the role that you're playing when you actually interpret these scans. So I hope this lecture is helpful to all of you. I wish you all the best for the rest of the meeting, and I hope you enjoy more of the lectures through the conference. Thank you.